Welcome everyone, and thank you for joining us today for our webinar titled Combining Telemetry and Ultrasound for Serial Investigation of Cardiovascular Function in Rats. This is Haley McCaffrey from Inside Scientific, and I will be your host for today's event. Our session is sponsored by Data Sciences International and will feature scientists presenting novel methodology of recording serial measurements of cardiac function in rodents using high-resolution ultrasound paired with implantable telemetry, permitting longitudinal study of load-independent indices and critical mechanical-energetic parameters of heart function. First, we will hear from Dr. Carlos Del Rio, Senior Scientist for Myocardia, as he presents a novel preclinical experimental design pairing DSI telemetry and high-resolution ultrasound to elucidate new insights of cardiac function in rats. There is significant power in the ability to serially record the same subject and track how disease progression affects cardiac function. Pairing these techniques allows conclusions to be made regarding load-independent cardiac function and mechanoenergetic parameters of the heart. Following, we will hear from Dr. Megan Fine from the Surgical Services team at DSI. She will present the advanced surgical model that has been developed to allow left ventricular pressure collection in rats. Advice for techniques that can help improve the surgical success rates and telemetry signal quality will be provided, and examples of optimized data will be shared. Finally, specific surgical and implant modifications that enabled concurrent collection of physiologic data from multiple telemetry implants in the same animal will be explored.
Thank you, Haley. Thank you very much for the invitation. It's a pleasure to be here. As Haley mentioned, we're going to be presenting some data, some experiments that we did in the lab in order to assess the feasibility of the serial assessment of left ventricular mechanoenergetic function in rats in the setting of disease. And why we're interested in mechanoenergetic states is because they are fundamental to understand the pathological remodeling of disease as well as the response to various therapeutic interventions. And what is more interesting about this mechanoenergetic state is that it's determined by the interplay between load-independent functional properties, be it lusitropy or inotropy, and the loading condition of the heart at any particular state. So even though most of the remodeling is a chronic process that takes time to develop, tools permitting the assessment of load-independent cardiac function in the chronic setting are very limited, particularly when it pertains to mechanoenergetic, load-independent mechanoenergetic parameters and small animals. So with that in mind, we sought to evaluate the feasibility of incorporating left ventricular pressure as derived via telemetry device with non-invasive high-resolution echocardiography in order to assess these mechanoenergetic states and left ventricular pressure volume relationships seriously in rats with both normal and altered diastolic function. So let's take a little bit of overview, because the idea of the interplay between cardiac function and loading condition is not a new story. It's there since the beginning. Particularly, we go to the Frank and Starling relationship. We know that the size of the heart plays, or the ventricular stretch during diastole plays a fundamental role in the force of the energy of the contraction. This was later recapitulated by Blake and others, which showed that the force-velocity relationship, the greater the stretch of the muscle, the greater the force or the velocity that can be generated at a given force, even though the maximal velocity that can be achieved is only altered by changes that alter the intrinsic properties of the function. This was later on taken into the in vivo setting of patients where the rate of change of the left ventricular pressure was used as a surrogate for this maximal pressure. And of course, we have to consider the integration of all these variables of the timing of the cardiac cycle as pressure and volumes interact and loading conditions. And Dr. Wiggers gave us a beautiful diagram that helped us understand how everything works together. Again, time, function, and load. So let's focus on the left ventricular pressure, because it's one of those tools that we have a very nice way to follow continuously by using telemetry. And it gives us insights on the mechanistic function of the heart. If we focus on the excitation contraction process, we know that it has different components. First, the entry of calcium into the cells, and then during contraction, the calcium opens the same filament that allows the myofilament to activate and contract, leading to contraction and the generation of pressure and ejection through the aorta. Following by that, we have the process of relaxation as calcium leaves the filaments, which unwind and is extruded, the calcium is extruded. After that comes the process of filling. So from the left ventricular pressure, and here in the slide, we have representative signals before in blue and after a positive inotrope dobutamine that show changes in some important parameters derived from the left ventricular pressure that give us insight on the systolic side, the contraction, both inotropy and clinotropy. For instance, we have the peak rate of change of the left ventricular pressure, and we see how it increases with an inotropic challenge, as well as the maximal velocity, the estimated maximal velocity of contraction of the contractile element shortening, as we can see here, that is derived from a normalization of the left ventricular pressure rate of change by the pressure occurring at any instantaneous moment. In addition, the left ventricular pressure gives us some insights into early relaxation on the process of extrusion of that calcium, removal of the calcium from the thin filament. For this, we generally leverage the minimum rate of the left ventricular pressure change of the DPDT mean, as well as the time constant of relaxation we can derive by fitting different models to the rate of fall of the left ventricular pressure following the end of systole, or from the pressure phase plane, where we can also derive a time constant of relaxation. However, none of these parameters occur after filling. All of these are before filling starts of the left ventricle. That's what is important also to consider volumes, and as we can remember from the Dr. Wigger's diagram, there is an interplay between volume and the pressure of the ventricle. So again, using a cartoon or representative signals before and after an inotropic challenge, we can see how from the left ventricular volume, we can get shortening ratios that reflect the ejection of blood through the aorta and how much cardiac output is produced. In particular, we have the end-diastolic dimension and then systolic dimension at the various ratios that we can use as the indices of systolic function. In addition, from the recording of these left ventricular volumes, we can get an idea of the isobolomic contraction time of early relaxation, as well as filling properties. And those are depicted here as the ventricle fills in two stages, one that is passive due to pressure gradient, as reflected by the letters E or E prime, depending on what tools we use. Another component that is the atrial component to this ventricular filling. So why it's important to consider all this together? And one of those parameters that those indices derived from the left ventricular pressure or volume independently are load dependent. And what do I mean by load dependent? Is if we change, for instance, the preload of the heart, if we reduce the stretch on the heart, the DPDT is going to change. Both the pressure is going to fall because the heart cannot eject what it doesn't get back to him, but the DPDT is also going to decrease, as we see it. And this has been shown before. Both ejection fraction and the DPDT have a dependency on preload. Similarly, we increase the afterload of the heart, in this case by inflating a balloon in the aorta, and we make the heart work against a higher afterload, we're also going to affect both of these indices. DPDT may increase slightly, and the ejection fraction may decrease as we increase the afterload, because the end-diastolic dimension is going to increase, but the amount of blood that is ejected is going to decrease. Again, both of these parameters are sensitive in loaded conditions. What tools do we have to correct for that? Well, we can combine load, we can combine volume, and we can combine pressure in what is called a pressure-volume relation, pressure-volume loop. And again, depicted here, we have in blue a resting condition, and in red, the inotropic challenge with the dobutamine. And let's go over the phases of these pressure-volume loops. First, we have end diastole, maximal volume, resting the filling pressure of the heart that advances during contraction following an isobolomic contraction time to the onset of ejection when the aortic valve opens. Then we have the third component and the fourth. The third component is the end of systole that goes into isobolomic relaxation time, leading to 4. That is the start of filling. So the mitral valve opens and then the ventricle regains its length. In addition, from this static relationship, we can derive the stroke work, the area of this loop, how much is the external work that is being produced or by the heart, as well as get an idea of the arterial load, the arterial elastance that the ventricle is in by the ratio of the end-systolic pressure to the stroke volume. Moreover, by using this relationship and the known load dependency of the changes in loading, we can generate families of loops during preload and afterload challenge. In this case, we have an example of an preload reduction, and then we can calculate the end-systolic and end-diastolic elastances, or the boundaries, the mechanical boundaries within those that the heart work. From the end-systolic pressure-volume relationship, we can derive the end-systolic elastance, which is a load-independent index of contractility, but it can also have some curvilinearity to it. And from the end-diastolic pressure-volume relationship, we can estimate the stiffness of diastolic compliance of the ventricle. In addition, we can combine the measurements of the stroke work as well as the diastolic dimensions to derive the preload recruitable stroke work, a linear index of contractility. So with all this in mind, let's jump into what we did. And again, what we aimed to pursue was the integration of the simultaneous integration of left ventricular pressure telemetry in rodents with that non-invasive high-resolution echocardiography in order to derive serially mechanoenergetic states pressure-volume relationship in animals, in rats. We achieved this integration by leveraging a DSI system, an analog DSI, and the combination of the R11 CPA platform that allows to take an analog telemetry signal and provide an analog output that was integrated into the visual sonic echocardiography system. In this setting, we performed two experiments. The first one was an acute evaluation that sought to answer the question, can this idea work? Is this a feasible approach that we can pursue in the acute setting? And for that, we tested the sensitivity of the system to acute inotropic challenges and pressure challenges with the butamine of phenylephrine in normal rats that were acutely instrumented. Once we completed that test and answered whether this was feasible, we moved into a second study, study B, where we use chronic instrumentation in order to assess the feasibility of the system to respond to chronic or remodeling. In this case, the pathological remodeling that occurs in CSF1 animals. These animals are characterized by diastolic dysfunction with the presence of a metabolic syndrome. So let's get into the data. First experiment, again, is can this work? Can this combination work? For this, we use acutely instrumented Sprague Dawley rats in which we place a PAC10 analog pressure transmitter from DSI into a carotid artery, advanced it retrogradely into the left ventricle. This gave us left ventricular pressures and rates of change, which then we incorporated, again, using the R11 CPA platform, into our ecosystem, where we collected a parasternal long axis view and used M mode to derive dimensions, real-time bit-to-bit dimensions that were integrated with the pressure generated by the system. I should note that other views are possible. We tested different volumetric views of volumetric assessments that depend on the M mode, and the system work as well. But for simplicity, we will stick with this presentation, this volumetric selection through the rest of the slides. So we were able to successfully integrate these two signals in order to obtain real-time pressure-volume relationships, which are depicted here for several bits. So in this setting, we tested the sensitivity to an inotropic and a pressure challenge. So what did an inotrope do? The butamine in this case shifted the left ventricular pressure-volume relationship to the left, providing a small decrease in diastolic dimensions as well as a reduction in diastolic pressures. There was a moderate increase in systolic pressures, as well as significant increase in the stroke volume, ejection fraction, and the DPDT max, as we expected for an inotrope. On the other hand, a pressure challenge with phenylephrine resulted in a right upward shift of the pressure-volume relationship, with an increase in end-diastolic pressures and end-systolic pressures, as well as a moderate increase in end-diastolic dimensions, moderate but significant. There was also a mild but significant increase in the DPDT max, with no changes in ejection fraction. So when we put all this together, we can also leverage this pressure-volume relationship generated acutely in order to differentiate these two compounds. For instance, when we fit or calculate the end-systolic or the arterial elastance, we see that the pressure challenge increased arterial elastance versus the dobutamine by the fact that increased stroke volume decreased this arterial elastance. Similarly, both challenges, one that increases stroke volume and one that increased pressure, increase the stroke work, the work of the heart. What else can we do with this tool? So for instance, we can leverage the fact that phenylephrine has a small inotropic component, what I will call almost a negligible positive inotropic effect, to derive an end-systolic pressure-volume relationship between the control state and the phenylephrine state. And once we have derived that relationship, we can fit or estimate the end-systolic elastance for dobutamine. Doing this across the state, we found that what we expected, that dobutamine is a positive inotrope that increases the end-systolic elastance. So in conclusion, can it work? The answer to that is a resounding yes. So we decided to move to the next stage, in which we wanted to answer if this tool can be helpful in the chronic setting and the more realistic setting. So for this, we chronically instrumented both CSF and control animals with Kyoto. This was done by DSI, and we prepared two groups of animals. One group was implanted with a standard digital telemetry for both left ventricular and arterial pressures. These animals were done for control to make sure that this modified system did not alter the response of the system. And the second group, the one that we'll focus during the remainder of the slides, were instrumented with a modified analog device, the PAC10, into the left ventricle. In both cases, the instrumentation was performed by DSI using an apical implantation technique. But I think this is perhaps a good time to ask why CSF rats and why we are leveraging this model in these studies. So why CSF rat? These animals are the combination of a soccer diabetic fatty female with an spontaneously hypertensive heart failure rat, and this combination leads them to present obesity, diabetes, hypertension, and nephropathy, so presenting a metabolic syndrome. So besides their good looks that remind me of myself, they also, and more important for this study, have a progressive cardiac phenotype that is characterized by diastolic dysfunction. In addition, they have a preserved systolic performance, which makes them a very suitable model for heart failure with preserved ejection fraction. This presentation, this cardiac phenotype, becomes apparent between 16 and 24 weeks of age, and it has been well characterized by other groups, which are much better than ours, leading to what I consider the greatest accolade in academia, a smiley face when it pertains to the fitting of the model to the presentation of disease, or the expectation of a disease in the clinical setting. So what is the CSF phenotype and why we're excited about it? So to confirm those studies by others, we acutely instrumented both CSF and control animals around the 18 to 20 week time point for pressure volume relationship and hemodynamics, as well as for echocardiography. And we see that they have a different profile. So the CSF animals are indeed hypertensive and they have elevated filling pressure, and both invasive hemodynamics and echocardiography confirm that. For instance, the E to E prime ratio is altered, in this case showing negative values for the E to E prime. So it correlates well with end-diastolic pressure, this increase. In addition, these animals have impaired relaxation and increased end-diastolic stiffness. Left ventricular time constant of relaxation is prolonged, end-diastolic stiffness increase, and then the filling patterns are also altered. The E to A ratio is low, which indicates, and we can see in the cartoon or the image, that the early component of the filling is impaired. So instead of the normal passive filling, these animals have an impaired passive filling consistent with the increase in diastolic stiffness. As we expected from the literature, these animals show preserved systolic function in which DPDT max and systolic elastance and EF are all slightly increased. And you will ask, well, Carlos, if all these indices are slightly increased, why are you saying preserve and not enhance? And you will remember from the earliest slide, all of these parameters, including the end systolic elastance, which is curvilinear, have some certain load dependence to them. The preload recruitable stroke work, in this case, we know is very linear and independent of load. did not show a significant increase, and therefore, rather than say enhance, we settled on a preserve on a preserved systolic function. Finally, these animals have an increased arterial load, increased arterial elastance, and preserve an hypertrophic remodeling, in which in the end-diastolic dimensions are vastly preserved, but they have a marked increase in left ventricular wall thickness. So in conclusion, it's a very cool, very interesting model, and that's why we decided to use it, particularly because they had that nice progression to disease over the course of disease. So how we follow these animals, we take them, we were implanted early, and between 16 and 24 weeks, we follow them every 4 weeks, focusing on the 16 and 24-week time points. And we followed in two components. One was an anesthetized left ventricular pressure in combination with echocardiography, again, using that parasternal long axis view in the M mode, as well as conscious left ventricular pressure. From the anesthetized assessments, we were able to generate pressure-volume relationships using the same techniques as before, using our 11 CPA platform to integrate the pressure and the volumes in real time. And the goal of the study was to answer is as simple as, is this technique sensitive to pathological remodeling as it occurs in these animals? Now to the answers. What do we get? Well, from the telemetry, as we will expect, we are sensitive to these progressive changes in end-systolic pressure and end-diastolic pressure. They were detected well by the system. There was no changes in heart rate between 16 and 24 weeks. We also can see that there is a preservation of the DPDT max between these two time points, but there is a progressive increase on the time constant of relaxation. So tau is prolonged, is more at 24 weeks than 16 weeks. What is also very interesting is, since we have left ventricular telemetry, it allows to test what are the effects of isoflurane, for instance, the anesthesia that we use for our echocardiography assessments. And in this case, it is very clear that isoflurane blunted this phenotype, decreasing both the end-diastolic filling pressures, as well as the time constant of relaxation, which was shortening the presence of the anesthetic, the inhaled anesthetic. These values, while approach or were decreased over those of the control animals, were still significantly elevated from control. But nonetheless, the phenotype was blunted by the presence of anesthesia. Now, when we include echocardiography parameters to our assessment, we can confirm that there is a preservation of ejection fraction between 16 and 24 weeks, and that there is a progressive increase on the wall thickness. Consistent with that progressive remodel, there was an additional mild increase in end-diastolic dimensions. Again, compared to the control, they are still comparable, but there was a slight increase as the animals grew. What can we do now when we integrate those two separate assessments between the left ventricular pressure and the echocardiography? As we saw before, we can derive the estimated arterial elastance, which was increased between 16 and 24 weeks. And we can calculate the stroke work, showing that there is an increase in stroke work as the animals progress in the disease. What is very helpful, I think we can go one step above. So we can answer the question now, will these tools be more than helpful? Will they be really helpful? And what else we can do that we couldn't do by separating telemetry and echocardiography and combining the data? So from the echocardiographic assessments, we can derive, or we have at the same time, the internal dimensions of the ratio, the diameter of the ventricle. We have the wall thickness, the continuous wall thickness, bit to bit, as well as an integrated left ventricular pressure, as you can see in the pictures. Well, we know from Laplace, and we use Laplace equation, that we can, taking all these variables, we can calculate the instantaneous wall stress. So with that in mind, we use Laplace equation, and we can convert that instantaneous left ventricular pressure into an instantaneous wall stress. What does that mean? That then now we can convert these pressure-volume relationship, static pressure-volume relationships, we can convert them into wall stress-volume relationships. Why is that important? Because then we can calculate, well, our peak wall stress, which is a very good correlator of energetic consumption, as well as our end-systolic wall stress, but another important determinant of an energetic consumption. So This will give us access to those energetic parameters of the mechanoenergetic component. But we're still missing the mechanic component. So what about load independent? What can we do to derive load independent using this technique? Obviously, we can perform loading alterations in loading. In the video, you see a preload reduction, and with that change in loading conditions, we can derive the end-systolic pressure-volume relationship at the PRSW, as we have seen before. This will be one tool that we could use. Alternative, we can use a pharmacological challenge, as we saw in the study A, to derive that equation and estimate the inotropic state of the ventricle at any particular time. However, in both cases, via the manual or the physical preload restriction of the pharmacological challenge, it requires manipulation. We wanted to test if we could achieve an index of load-independent contractility without any manipulation. And that is where the combination of the use of that wall stress come in handy. So when we compare the left ventricular pressure volume into a wall stress volume, then we notice, or we know, there is a linear relationship during the late systolic component of that. And that has been shown before, and it was confirmed in patients as well as preclinical spaces, that the slope of this relationship between the late systolic wall stress and left ventricular volume is a load-independent index of contractility reflecting the inotropic stress of the ventricle. So once we incorporate that into an analysis of our data, we calculate the slopes of that relationship, and we confirm that these animals have indeed preserved inotropy. Despite the changes in loading, they have a same inotropic state both at 16 and 24 weeks. So in conclusion, can these tools be combined and can they be used to derive mechanoenergetic states serially? The answer to that, again, is a resounding yes. So to conclude, we know that we can use serially left ventricular pressure telemetry, and we know it's very valuable as it gives us indices of both systolic and diastolic performance. And what is important, we know that we can use that tool serially in conscious animals that are free of the constraints of anesthetic agents and preserve autonomic tone. We also know that we can leverage echocardiography serially because it's a sensitive index that provides us indices that are sensitive to cardiac remodeling, as well as it gives us both systolic and diastolic indicators. However, when we combine these two tools in order to provide simultaneous readings, including pressure-volume relationship and wall stress-volume relationship, now we have a tool that permits the serial load-independent assessment of mechanoenergetic parameters. So in conclusion, yes, it is feasible to integrate telemetry to get left ventricular pressures and non-invasive high-resolution echocardiography to permit the serial assessment of mechanoenergetics of the heart. And we have shown this in both normal rats as well as rats with altered cardiac function. Thank you for your time. But before I sign off and take any of your questions, I would like to acknowledge the work of the people that made this work possible. In particular, I would like to thank Chris Sabataro at Myocardia, which did pretty much all the experiments, as well as John and Terence at DSI that made this happen, as well as Megan, Heather, and the surgical team at DSI. Finally, I would also like to thank rats number 232 and 396, which representative signals and good looks are shown in this slide.
Thank you. I'm happy to be here today, and I will get started. Today, I'll be talking about the surgical aspects related to this project. I'll start by covering the perioperative animal care and cover the surgical procedure itself. Finally, I'll close by sharing some customizations we use to support this specific model that involve the implantation of 2 devices in each animal. I'll start by talking about the surgical preparation because the planning before and animal care after the surgery are as important as the surgery itself. Due to the invasiveness of the surgery, which is considered a major procedure, we always administer a non-steroidal anti-inflammatory medication preoperatively in order to help maintain comfort and prevent the development of wind-up pain. Non-steroidals are continued post-operatively, and we also include an opioid pain medication in our protocol for use as a rescue drug in case the NSAIDs don't provide enough pain relief. All animals are carefully monitored by DSI surgeons both intra and post-operatively. We've recently updated our post-op scoring procedure to use these color-coded cage cards shown here that have separate space on the back of the card to record notes cage side. So rather than using a strict numerical scale, we've created a type of visual analog scale. And as a veterinarian, I can come into the room and quickly determine which animals need additional care or attention. We use isoflurane gas anesthesia for induction and maintenance. The gas anesthesia allows us to alter the depth quickly and easily, and later I'll talk about how this can be particularly helpful when using a hypertensive rat model. Because we will be opening the chest, we need to use positive pressure ventilation. We use a snug-fitting nose cone shown here to seal around the outside of the animal's face. This avoids the need for endotracheal intubation and allows for increased surgical efficiency. Regardless of the animal species, aseptic surgical technique is critical to preventing infection and maintaining animal welfare. We have found that we do not need prophylactic antibiotics to prevent infection because of our strict attention to aseptic technique. Animals are prepped for surgery at a location separate from the surgical table to avoid contamination here. All instruments and supplies are sterilized for each surgery, and surgeons wear new sterile gloves for each animal, along with a cap and surgical mask. Most importantly, surgeons are fully trained in aseptic surgical techniques to ensure they maintain sterility throughout the procedure. We perform the majority of our rodent surgeries under a microscope, but it's not possible to use the microscope with this surgical approach because we'll be accessing the apex of the heart through the diaphragm. So, for the left ventricular cannulation portion of this surgery, our surgeons sit on a stool lowered to the height of the surgical table and use loops with a magnification of 2.5 to 5 times to visualize the heart through the diaphragm. We also use a high-quality surgical light attached to the loops to illuminate the surgical field. If systemic blood pressure and ECG leads are also being implanted, this portion of the surgery may be completed under the microscope. Because we'll be accessing the heart through the diaphragm, we'll need to retract the chest wall to allow for adequate visualization and surgical working space. We use the magnetic arch assembly shown here that was developed specifically for this purpose to lift up the body wall and expose the diaphragm and the apex of the heart. Here's an image of the chest being lifted by the magnetic arch. You can see the hooks engaged in the body wall at the top of the picture. You can also see the incision through the diaphragm that we use to access the apex of the heart. We place stay sutures in the diaphragm and secure them to the sides of the body wall to open the incision in the diaphragm and allow for good visualization. The liver is packed with moistened sterile gauze and a retractor is placed to protect and retract the tissue. In a few slides, I'll be describing the trans-diaphragmatic surgical approach to the apex of the heart in more detail, but right now I'd like to give you the background on why we have selected this surgical approach. One major reason we favor this approach is the direct access that it provides to the apex of the heart. Once the heart is exposed, it is critical to identify the true apex so the catheter can be placed in the center of the lumen of the ventricle. The apex can be identified as a palpable softening in the muscle and can be visualized as the point where the coronary blood vessels form a swirling pattern. If the catheter is placed off-center or placed at an angle rather than straight into the lumen of the ventricle, the tip can become lodged in muscle, stuck under the trabeculae, or encased in fibrous tissue, all of which will compromise the waveform morphology and the quality of the telemetry signal. Another reason we like this approach is because we are also typically placing the implant body inside the peritoneal cavity to accurately measure a core body temperature and inserting the catheter into the abdominal aorta to measure systemic blood pressure. Therefore, we can access these multiple sites through this one incision. The alternative approach for left ventricular pressure catheter placement is through an intercostal thoracotomy. This approach increases the invasiveness of the surgery, especially if the abdominal cavity must also be accessed, and careful apposition of the ribs is required to minimize substantial postoperative pain. It also requires the catheter to exit the apex of the heart and make a sharp bend at the diaphragm, which can affect the left ventricular pressure signal if the catheter becomes torqued to the side and the tip impacts the inside of the heart. If systemic blood pressure and/or core body temperature are also required, the animal will have to be repositioned during surgery, which can increase the risk of complications such as infection. Comparatively, the trans-diaphragmatic approach allows for easy access to the abdominal aorta for systemic blood pressure. It allows the catheter to exit the apex of the heart and travel straight and unkinked, and it avoids having to reposition the animal during surgery. Now I'll walk through the surgical steps on a high level and can provide more detailed information offline for anyone who may be interested. First, the animal is prepared and placed in dorsal recumbency, and a ventral midline laparotomy is performed. Once the abdominal wall is opened, the hooks in the magnetic arch assembly are used to elevate and open the incision, retracting the chest wall. Next, the beating heart can be visualized through the diaphragm, and an incision is made in the diaphragm over the heart. Stay sutures are placed on either side of this incision to open the diaphragm and provide access to the apex of the heart. Once the heart is visualized, an anchor suture is placed in the muscle of the right ventricle to allow gentle traction to be placed on the heart to expose the apex. Because this portion of the surgery is essentially performed in a tunnel, a self-locking needle drivers like this pair of Castroviejos is used. Next, the apex of the heart is identified, and a purse string suture is placed over the apex using a 3-bite technique. The purse string suture should be started and ended ventrally or on top of the heart as you look at the apex. This way it's easier to tie the knots on top of the catheter once it has been inserted. The catheter is now prepared by removing the protective tip cover, replacing any missing gel at the tip of the catheter if necessary, and tying a piece of suture in the suture aid near the tip, shown here. It is helpful to use a suture that is a different color from the purse string suture that places in the heart, so you can make sure to tie the correct sutures together when securing the catheter. Using a 20-gauge hypodermic needle, the apex of the heart is punctured in the center of the purse string. It's important to angle the needle so it's aligned centrally within the lumen. Blood should come freely from the hub of the needle. If no blood is seen, it's likely that the tip of the needle is inside the muscle and not within the lumen. Placement of the catheter here would lead to an inappropriate left ventricular pressure signal. Next, the catheter is grasped behind the distal thin-walled pressure-sensing tip using a specialized vessel cannulation forceps depicted here and inserted into the needle tract after the needle is removed. The catheter must be inserted at the same angle as the needle into the lumen. It's important to watch the live telemetry signals during these surgeries to confirm that the catheter is placed correctly and that the signal quality is good. If necessary, the catheter can be repositioned at this time, which may mean repuncturing the heart with the hypodermic needle to achieve the correct placement and angle of insertion. Next, the catheter is secured in 2 steps. First, the purse string suture in the heart wall is fully tightened and multiple square knots are tied. Then, one of the purse string suture tails is tied to one of the tails from the suture previously placed around the catheter within the suture aid. Finally, the remaining 2 tails are tied together. The diaphragm is closed using a simple continuous pattern, suturing from dorsal to ventral with a catheter exiting near the ventral aspect of the incision. Once the diaphragm is closed, a butterfly catheter is passed between the ribs into the thorax, and the needle tip is visualized through the diaphragm. A syringe is connected to the tubing, and the air is evacuated from the chest to allow the lungs to fully reinflate. The surgeon should be prepared to re-evacuate the chest should the animal show difficulty breathing when being weaned from the ventilator or during postoperative recovery. Next, I'll discuss some of the ways that we have optimized the surgery over the years, and I will provide some recommendations to help you become successful with the techniques. When we're working with a hypertensive or otherwise unhealthy animal model, we try to perform the surgery before the animal has developed substantial disease if possible. Even then, some of the strains will have an elevated blood pressure at the time of surgery, and the myocardium itself appears more friable. These animals may have substantial hemorrhage when we manipulate the heart or puncture the left ventricle. Therefore, we capitalize on the cardiovascular depressant effects of the gas anesthesia and increase the isoflurane concentration during the cardiac and aortic cannulation portions of the surgery. We prefer animals with a body weight of approximately 225 grams. At this size, the animals are large enough to comfortably accommodate the implants. They're typically hardy enough to survive the surgery and recover well, but they aren't too hypertensive or too obese to obscure the surgical access and visualization. We always recheck the telemetry signals once the animals are awake and have returned to their normal posture. This can sometimes cause a change in the waveform morphology due to a shift in the relative positions of the heart and catheter when the animal goes from dorsal recumbency during surgery to an upright position. Therefore, animals with inappropriate signals may need to be replaced prior to use on study. If we have any signals that are unacceptable, we always open the heart and look at the insertion point and alignment to see if there's anything we can learn. We check to see that the tip of the catheter was inserted exactly at the apex and aligned correctly within the lumen of the ventricle. If the tip of the catheter is still in good condition and the pressure reading is very close to zero, it is possible to re-sterilize and reuse the implants. The implants are first treated with an enzymatic detergent to remove any blood and proteins, and then they're sterilized with Actrol, which is a cold sterilant, and finally they're thoroughly rinsed with sterile saline before reimplantation. We found that the implants should not be stored overnight in sterile saline because it softens the catheters too much and makes it really difficult to reinsert them without disturbing the biocompatible gel at the tip, which is critical to obtaining a good signal. Animals were implanted with 2 telemetry devices for the project that Dr. Del Rio described. In the next few slides, I'll discuss some of the implant solutions and surgical accommodations used to ensure the success of the model. The major requirement we needed to satisfy was the ability to collect an analog left ventricular pressure signal in order to combine the analog data with the data that Dr. Del Rio was obtaining through echocardiography. In order to meet this requirement, the PAC-10 Tox implant was selected for its analog output capabilities. The implant has been used for a variety of purposes, such as blood pressure measurements in mice, and it has been placed minimally invasively in large animal models to add blood pressure data to toxicity testing, but it isn't typically used for left ventricular pressure measurements. So we had to place a high-frequency catheter with a suture aid on the device to allow Dr. Del Rio to collect the high-quality data he needed, and so our surgeons could adequately secure the catheter inside the heart. A suture rib was also placed on the device to allow it to be secured inside the abdomen. Dr. Del Rio was also interested in collecting systemic blood pressure and ECG data simultaneously with left ventricular pressure measurements. To meet this need, we offered dual implantation with a second device, the HDS11 implant. This device is available in a model that transmits on a second frequency, so data could be collected from both the PAC-10 and the HDS11 at the same time without concern for interference. In order to collect data on both transmission frequencies, a RP3C receiver was used. Surgically, we were able to implant both of these devices in the same animal without any issues. The PAC-10 is a small and lightweight implant and was secured using the suture rib to the inside of the abdomen off to the left side, leaving room for the HDS11 implant to be placed on midline. The HDS11 implant was used to capture systemic blood pressure by inserting the catheter into the abdominal aorta. The implant also measured ECG, core body temperature, and activity using routine surgical placement. This diagram shows the connections between the pieces of hardware required to record the left ventricular pressure signal concurrently with ECG and blood pressure with the 2 implants. The PAC-10 implant's recorded left ventricular pressure is converted to analog signal to be processed in visual sonics. There are a variety of other telemetry signal combinations possible using dual implanted animal models. Some of the possibilities include combining blood pressure with other signals such as blood glucose, which is shown in the picture here, right ventricular pressure, pulmonary artery, or intrapleural pressure. Various additional novel combinations could also be accommodated. So to conclude, I've discussed some of the intricacies of left ventricular pressure surgery in the rat model. More specifically related to Dr. Del Rio's research, I've summarized the optimizations needed to allow the successful collection of analog left ventricular pressure data simultaneously with digital systemic pressure, ECG, temperature, and activity data.
Thank you both so much for sharing your research today. So now I'm going to ask Dr. Del Rio to rejoin our audio line, and we'll transition into a Q&A. Lots of questions have come in from the audience, so let's get going. Megan, this first question is for you. A couple of people have asked, can this procedure be done in mice?
Sure, good question. Thank you. We typically don't perform this surgery in mice. Because of the size, some surgical challenges. However, I do think that there are maybe a few researchers out there who have attempted it. So for more specific questions, I just refer you, just contact TSI Client Services or your sales rep, and we can talk one-on-one and maybe make some connections if needed for that.
Great, thank you. Carlos, this next question is for you, and it's coming from Kimberly. Based on your data in the ZSF1 rats, do you consider this a good model of heart failure with preserved ejection fraction relative to what is known in humans?
Hi, Kim. Thank you for joining. Great question. I think out of the models that are available out there is one that I feel the most comfortable trying to mimic the disease, because it has two features that I think are essential. One that is a syndrome, it's not just a single cardiovascular challenge. And the second, it has elevated filling pressures. Those two, I think, are fundamental to recapitulate the presentation of the disease in patients. In addition, other groups have shown that they have impaired exercise capacity, reduced peak VO2 max. So I think it's a good model. Overall, is a model, and we generally need to complement them and not use it as a sole model. But I think it does a very good job. Smiley face, as that review showed.
Great, thank you. Are there any complications in rats with left ventricular pressure telemetry implantation?
Yeah, also a good question. I talked a little bit about preventing some of the complications during the talk, but I'll just go through high level on some of those and other issues. So one of the potential issues could be signal quality issues. So the surgery could go great, but you might have a LVP signal that doesn't look good and may not be usable. So a few of the tips and tricks to help prevent that are just really making sure that you identify the center of the apex of the heart, and then angle the catheter straight into the lumen of the ventricle. So even if you puncture at the right site, if you're at an angle, the tip can hit the inside of the heart wall and you'll get some artifact. And then inserting there's that suture aid on the tip of the catheter that I had a picture of, and you want to insert, so that suture aid is flush with the outside of the heart wall, and that'll put the tip at the right depth. So if it's too deep, you risk having the tip kind of impacting on the inside of the heart wall, and if it's placed too shallowly, you risk having the muscle contracting on the soft or the thin-walled tip where the pressure is sensed at the end of the catheter. So those are a few of the tips and tricks for that. Another one is making sure that the catheter exits the diaphragm where it will exit when the animal regains its normal posture. So if you think we're doing the surgery in dorsal recumbency, everything settles a little bit dorsally, and then when the animal is normally in kind of a sternal posture, everything shifts a little bit ventrally. So keeping that in mind as well. And then just learning and checking if there's anything that's, if you have any that have inadequate signals, looking at those to try to learn from. A few other potential complications can be hemorrhage, which, like I mentioned, can be worse in the hypertensive models. So increasing the isoflurane for that. And then with this surgery, as other surgeries, you can have anesthetic complications. So that's why we like to use the inhalational anesthesia, so we can quickly change the depths. We'll use different monitoring equipments and have the surgeons monitor, so things like pulse oximetry, so we can see how the animal's doing. We also try to avoid drugs preoperatively that could be pretty depressant. So for example, some of the opioid medications, as well as like alpha agonist sedatives, or some of those would be used in injection anesthetic protocol, and so those can be pretty cardiovascularly depressant as well. And then, like I mentioned, just making sure that the lungs are fully inflated and the chest is evacuated, and then being ready to re-evacuate if you need to after surgery. Those are kind of more specific to this surgery itself.
Perfect. Thanks, Megan. Carlos, this next question is for you, and it comes from Alex at the University of Louisville. Could you clarify how you synchronize the left ventricular pressure data with the echo data? Was this just done in Excel on a beat-to-beat basis, or did you have software that ensured accurate beat matching?
That's a fantastic question, because as you may have noticed, my presentation was a little bit thin on the technical details. So the analog signal comes into the echo machine where they are acquired together, then they are exported, and either Excel or using data analysis software, we need to find out what is the correct alignment of those signals, and that's why having the alternative, that's why we wanted a second signal that will allow us to synchronize, and that's where the second telemetry device comes into play. So for each acquisition, we have not only the acquisition in the echo machine that integrates left ventricular pressure with the echo data, but we have a second acquisition that collects the telemetry signals from both devices at the same time, and that allows us to synchronize. There is a delay in the echo data, about 10 milliseconds. It's not terrible, but it needs to be corrected because it can really affect isovolumic contraction times and isovolumic relaxation times. So it's an excellent question. Along the same lines, I think I'll mention it in case the question comes. If you have used the R11 CPA, you know that setting the calibration is something that requires a pointy hat and the right phase of the moon. So what we did to circumvent that issue, we fixed the settings on the device and always collected with the same settings. And given that we are collecting simultaneous signals with the calibrated software, then we just use that to correct that calibration. So in general, that summarizes, and there are two questions along the same line. I hope that helps. If not, please feel free to contact me.
Perfect. Thanks, Carlos. And we'll just have one more last quick question. Christy is wondering, have you noticed any sex or gender effects on cardiac function in the ZSF1 rat? Sorry.
Good question. Thank you for joining, Christy. No, we haven't looked for it. It's a fantastic question because HPEF particularly, there is a difference between male and females on the incidence of the disease. And it will be very important to test this, but for these proof of concept studies, we stuck with male animals. But great question.